I had one more question, Les, about the this ILAs, the interstitial lung abnormalities that you get in patients who are not really, my understanding, but correct me if I'm wrong, Les, about this. These are radiologic abnormalities that you see on high resolution CT that seem interstitial in patients who don't have clinical symptoms of interstitial lung disease. Is that the correct way to look at this ILA thing? And then what do you do with them? Do you treat or do you follow? What happens with these cases?
Yeah, so I think that that is a good general description, right? It's almost sort of like incidental ILD, where you're finding it and you don't really know the significance of it. Um, and the question I think of what do you do sort of depends on what it looks like, how bad it is, you know, going back and asking the patient, right? Like maybe you do have symptoms and you didn't realize it, right? Like a lot of people think it's normal to get short of breath as you age, but it's really not normal to get short of breath as you age, right?
Mhm.
You can get out of shape, you can get overweight, and that can cause shortness of breath. But like aging in and of itself shouldn't really cause significant shortness of breath. And so sometimes you have to go back and ask them a little harder, like, and then you find out, oh, right, maybe this is significant. And sometimes we see disproportionate findings that can be tricky. Like if you've got frank UIP on a CT, but they're really like asymptomatic and you're like, well, what do I do with that now?
Yeah.
And so these ILAs can be pretty tricky.
Yeah. I mean, we do run into those from our perspective too, because we get lobectomy specimens
Yeah.
where the main issue is cancer, but there's an, quote unquote ILA in the background. So, I mean, thankfully, many of those are SRIF and don't need, nothing needs to be done. But the ones where there is where there's UIP, for example, in the background,
Yeah.
or CPFE in the background of a lung cancer, I always wonder what you guys do with that information once you have pathologic confirmation that
Yeah.
there is UIP or CPF. Does that change your calculation on what to do if you have
Yeah. It
pathologic
sort of
confirmation?
it sort of has to almost, right? Like, I mean, I get like maybe one or two of those a year where, a lobectomy where they found UIP and I was like, wait a second, what? Right. And sometimes you can see it on the CAT scan and sometimes you can't, right?
Yeah, yeah,
And so at that point, like they have a pathologic diagnosis, and you have to sort of go searching for it, um, and try to figure it out as best you can, and then you try to make a decision of treatment based on what you find. And it may be like what I was saying before, where someone like that, you may observe them to see if their disease progresses before you start treatment. It gets really tricky in that scenario when it's sort of an incidental finding like that. It doesn't happen as often on pathology than it does on radiology, certainly.
yeah,
Yeah,
yeah.
those are really tricky ones. And I always worry that when we're sampling a lobe and we see some fibrotic disease, we only have one lobe. And I'm always a little hesitant to call underlying fibrotic disease when I only have sampling of a single lobe. I always worry that maybe it's just a cancer causing something. There's some localized thing. Is that fear real, or I don't know. What do you think?
I would almost turn that question back on you guys, right? Like I I don't have a sense of what is the normal amount of scarring in a human lung at age X, right?
Yeah.
Like I said before, we inhale a lot of stuff, and that stuff causes damage in our lungs. And you could imagine a scenario like just like your skin, right? Like you have scars all over your skin from injuries throughout the years. You got to imagine there would be some amount of fibrosis in a normal lung just based on bronchitis and whatever you had over the years. And so I would almost turn that back on you guys to sort of say what this looks abnormal versus normal. I don't know.
Yeah, that's a very interesting question. I mean, on one level, it's very funny that we make a UIP diagnosis on a transbronchial cryobiopsy, but when we have an entire lobe, we're
Right.
we're, we're worried about whether we have enough tissue.
Right.
That at one level, that's funny, but on the other level, there are many other things that can confound this issue, Les.
Yeah.
Like, for example, in the upper lobes, scarring at the apices is very common. You know,
Right.
the so-called pulmonary apical cap, this
Yeah.
fibroelastotic scarring, very, very common. That can make things difficult. Of course, SRIF is very, very common in smokers. That makes things difficult. That can overlap with UIP, as you know. So I think from a pathologist perspective, you know, we are always worried that we are overcalling. You know, we're worried that there might not be something clinically significant, but we're making a big deal out of it on pathology. I think all pathologists are worried not to overcall UIP because in our mind, you know, we're like, this is a death sentence for the patient. We should not be overcalling this. So I think on the whole, we undercall. We undercall in these lobes.
And I think that's where the communication really comes into play, right?
Yeah. Yeah.
Is that like I need to get a sense from you, like are you undercalling? Are you overcalling? Like, how hard do I need to look? Is there a real problem here or not? And I think that whether that's in the formal MDD or sort of an informal phone call conversation, uh, that's uh, that's what's sort of important about this. And I am fully cognizant of the fact that I am spoiled rotten, right? Like I have a radiologist in clinic with me. I can page or text, one of what, four pulmonary pathologists now, right?
Right. Yeah.
And so uh, it's easy for me, whereas it may not be for other people that either have one for an entire country,
Yeah.
right? Or half a country, right?
Right.
Or there's one for their institution, or you don't have any,
Yeah. Yeah.
right?